Hello, everybody. My name is Meredith Hockman. I'm sure you have seen many emails from me over the last couple of weeks. I am one of the program managers at Central Maryland Area Health Education Center, and we are hosting this wonderful event, Mental Health and Suicide Risks in Later Life. I'm so excited to have all of you here today. I am just going to do a quick little bit of information for you, and then we'll get started. If you have any issues, please feel free to send me a chat through the chat box. You'll also see in the chat that there is a link to our pre-survey. If you haven't done so at the break, please take a moment to do the pre-survey. It's important for us, for our funders, and we appreciate any information you can provide us. I do want to take a second and thank Diane Martin and G Gear for helping us, as always, to put on amazing events, both through funding, but through support, including the wonderful Min who is here too. I want to thank both of you for just helping us get this going. And I appreciate everybody's time and effort for Central Maryland AHEC. I think you're going to have a great afternoon. I also included in the chat box our resource page, and I will put it up there a second time. It's a file. Feel free to download it and use it, and it has a lot of great information about all of the topics that you're going to be hearing. And if you have, again, any issues, please feel free to give me just a shout out in the chat room. And without further ado, I'm going to turn it over to Diane Martin. Diane.
Good morning, everyone. Welcome to the second in a series of 3 conferences that is being hosted by the Central Maryland Area Health Education Center. We're really happy to be partnering with the Central Maryland AHEC and the Marylands across the state of Maryland to bring these types of conferences to you. My name is Diane Martin, and I am the director for the Geriatrics and Gerontology Education and Research Program at the University of Maryland in Baltimore, where I'm also an associate professor in our graduate school. We are pleased to have nearly 150 professionals and students join us from across the state and beyond on this snowy morning. I appreciate also we have Kim Burton, who's a wonderful speaker, and Cindy Richard, who I've also heard speak when I've hosted other conferences. So I'm very happy to have both of these speakers with us this morning. And Cindy, like myself, lives in Pennsylvania, and we had a pretty good dusting of snow here this morning, several inches. So I'm grateful that we're actually doing this virtually because we may have had difficulty coming down into Maryland this morning. But over the course of the next several hours, you're going to learn more about the important topics of mental health and suicidal ideation in later life. This is a really important topic because nearly 1/3 of older adults who attempt or complete suicide actually see their primary care physician within 1 week of their attempt or their completion of suicide, and 70% of older adults see their physician within 1 month prior to their attempt or their completion of suicide. Unfortunately, these statistics have not changed over the last 10 years or so, actually over the last 30 years or so. However, a broad review of cases over the last decade has revealed to us that the warning signs and language used by older adults is often unrecognized by their families, but more importantly, by their physicians. These words that they're using, the way that they're presenting, is not recognized as being suicidal. The research shows us that nearly 1/2 of patients who did complete suicide presented with psychiatric symptoms, yet these symptoms were recognized in less than 1/3 of the patients. Treatment was offered to less than 25% of those cases, and the treatment rendered was considered adequate in only 2% of cases. We have to do better, right? Oftentimes these cases are missed because people, including their physicians, their families, and even the patients themselves, think that depression is a normal part of the aging process. It is not. Right? The rate of depression in later life, people who are 65 and older, is no greater than any other age group. Yet their suicide rate is 50% higher than the general population. The suicide rate in older adulthood, men in particular, is the highest. And then when we get into the 80+ population, it is even higher than the 65 general population. So throughout this morning's activities, you're going to learn more about depression and mental health in later life. You'll gain an understanding of suicidal behavior in older adults, and you'll gain effective strategies to reduce elder suicide. Because we are going to be talking about very sensitive subject matter, we want you to feel free to do what you need to do to take care of yourself if you become distressed. If you need to hop off or take time away, we understand. We have many people on this webinar, however, and we're not in a position to best support you the way that we would be if we were in a live venue. There is help available should you need it. And you'll see that Kim Burton posted in our chat box how to connect with resources available in Maryland by phone or text. And Kim, I'm going to ask you if you could just copy and paste that again, because that was very high in the text chat box and I wasn't able to go in and move it. So if you could just do a copy and paste to everyone again, that would be wonderful. All right, at this time, I'm going to welcome our keynote speaker. We're pleased to have join us this morning, Senator Addie Eckardt. Senator Eckardt is very, very familiar with the topics that we're going to be addressing this morning. She represents District 37 of Dorchester, Caroline, Talbot, and Wicomico counties. Her bio is in the program book, but by way of introduction, let me highlight some of the appointments and accomplishments related to this conference. Senator Eckardt is a member of the Health and Human Resources Subcommittee and is the Senate-appointed member of Behavioral Health Advisory Committee, the Governor's Commission on Suicide, and the Governor's Commission to Study Mental and Behavioral Health in Maryland. Senator Eckardt retired in 2003 from the Eastern Shore Hospital Center, where she had been employed as a full-time psychiatric mental health clinical nurse specialist since 1973. She is a graduate of the University of Maryland School of Nursing with a Master's of Science degree and maintains certification as a psychiatric nurse clinical specialist by the American Nurses Association. Please welcome Senator Addie Eckardt.
Thank you very much, and I am honored to be here with you all in this beautiful snowy morning. It's a wonderful opportunity to gather together, particularly to talk about issues that are very important and vital to maintain the mental health for all of us, particularly those of us who are aging in place. So thank you for this opportunity. What I wanted to do this morning was to give you a little bit of a background of our legislative session. You know, through the pandemic, it's been a very challenging time, and it's a good opportunity for those of us who are in the health field to really channel our energies and do the best public health work that we can. But for many people, it's been an additional stressor. You know, looking at the isolation of the multiple losses that have been experienced through the pandemic, whether it's loss of job, loss of income, loss of contact with loved ones, just a basic interruption, the uncertainty and the unpredictability about what's going on has been a very challenging time. But we're back in legislative session trying to normalize things as much as possible and to be able to jumpstart the economy and get families and communities back to work and back to some degree of normalcy. So if we go to the first slide, I just wanted to give you the background of what's happening here in Annapolis. All of our bill hearings are now virtual. That means some of the legislators can be at home, some can be here in Annapolis, but everything is live streamed for the public, for you all to stay up to date on the very latest legislation and happenings. The Senate and the House building are closed to the public, but it may be reopened based on the COVID metrics and safety protocols. Right now, those of us who are here in the Senate are tested twice a week. Many of us have had our second COVID vaccine. Those who want it have already received their first injection and probably will be scheduled for their second one. Governor Hogan has introduced his budget, and the legislation that we've worked on now, both in the Senate and the House, to add to that relief and recovery package is designed to help those who are greatly impacted by the pandemic. That's our businesses, our not-for-profit groups, our homeless folks. Retail particularly has been hit hard. So how we can help folks be able to, again, get back to business and get back to some degree of normalcy. To date, we've introduced about 1,500 bills, and a lot of what I focus on, as you can imagine with my background in psych mental health, has been to look at our health workforce, mental health, suicide prevention and intervention, because that's been a vital part to me and what I consider the core basics of any psych mental health practice. So first of all, I've introduced Senate Bill 13, which would expedite the kind of entry or re-entry for our CNAs. And our nursing homes have been particularly hard hit with COVID, as you know. And so we have quite a workforce out there, but many of those nursing assistants have been out of practice maybe for 2 years, and this would expedite their training through the Board of Nursing. Senate Bill 56 is the Maryland Medical Assistance Program, psychiatrist and psychiatric nurse practitioner, telemedicine reimbursement. We have lifted the sunset on that because we know that access to services for our those folks who struggle with severe and persistent mental illness is really critical. And telemedicine has been a godsend. Actually, we put some things in place, bills that passed at the end of last year's session so that we could continue to reach folks digitally or by phone. And for many individuals who struggle with mental illness, that's been very helpful because we can maintain contact and you're always a phone call away. And that's been great as we've fleshed out the crisis intervention, used the 211, press 1. All of those services are critical at this time. So we want to keep that. Senate Bill 92 and Senate Bill 102 actually expand the possibility for our preceptors. Those are those nurses, advanced practice nurses, or doctors, primary care, and our nurse practitioners to precept both other nurse practitioners and other physicians. We want to maintain the hours and then lift the sunset because that has been a very helpful program, and then to expand that to physician assistants. I also introduced a bill, and it was co-sponsored in the House, that would look at studying access to mental health care in higher education. We know that as we've instituted psych mental health services through our school-based models, that many times there are students who go off to higher ed and don't have that same level of support or intervention. So this bill would take a look at those services through our community colleges and higher ed, our universities and other schools, to be able to see what is in place, what is working, what isn't working, and then make recommendations for developing some kind of common core services that could be shared throughout the state. The other biggie is a suicide review fatality committee, or a suicide fatality review committee. This is an initiative based on my understanding of our infant mortality review boards that are currently operating around the state. And then there's an opiate fatality review committee in place as well. But Maryland, when we go and review deaths through the medical examiner's office, have to be clearly and convincingly a suicide to be declared death by suicide. But there are many times it's not clear what the evidence is to indicate whether it was clearly and convincingly death by suicide. And that's undeterminable. So they go into a separate category. Many other states have refined their criteria to look for other indicators. And what we want to do with this Suicide Fatality Review Committee is to be able to look at and tease out other information by reviewing records, by getting more information, to be able to see if in fact we need to change that criteria. And we may have some clues that would, as we heard in the beginning of the introduction of the program today, are there other indicators that we are missing? Is there an age difference? We know that some folks housed their pets or gave their pets away in other states. And how do we determine that so that we can then make some recommendations and provide information and education early on to begin to interrupt suicide? One of the things that I think is really critical to think about when we're talking about suicide is that it's an ambivalence. So the will to live and the will to die are coexisting. And so it's really critical that as early as possible, we can throw somebody like a lifeline. That's the earliest intervention. So all the indicators and all the factors that are present, again, as soon as we can get a clue that somebody's contemplating suicide, it's easier to throw a lifeline and then begin to reel in and provide those kinds of resources to interrupt it. Senate Bill 13 is another bill that will allow the Board of Nursing to provide a refresher course for nursing assistants who's been out and may come back in, who've let their certificates expire, and they will develop that. We also, next slide, please. Thank you. So telehealth, as I said before, it's really important. So again, we want to maintain those services through the medical assistance program. And we also want to make sure that we are able to continue that through the end of the pandemic and then after that, because it has been so valuable, but we need to have the protections in place, and we will make sure that we do that as well. Senate Bill 557, or Suicide Treatment Improvements Act, requires the Maryland Department of Health to provide additional training for staff who are assisting callers on a hotline to make sure that they're able to provide that lifeline, that they're able to ask the right questions, to be able to determine then who's highest at risk and be able to get that early intervention going. So that will be really important. Senate Bill 550 is the Sheila Hickson Behavioral Health Services Matching Grant Program for service members and veterans. Again, we know that there's a high incidence of suicide in our veteran population. So we want to make sure that we can provide those funds necessary for our nonprofit organizations to establish and or expand our behavioral health programs to serve our members, our veterans, and their families. And with that will be operated through the Department of Health as it is passed. Next slide, please. So there are many of the bills that are moving through both House of Delegates and the Senate, but there are others, so stay tuned. The budget, let me just share a little bit with you about the budget. There's nearly $13.5 billion for Maryland's Medicaid program that provides health coverage to 1.5 million Marylanders. Over the years, we've pretty much provided access to health care for nearly all of our citizens, and we want to continue to maintain that. That includes 143,000 children through the Maryland's Children's Health Program. There's more than $1.4 billion in support for a developmental disabilities community. That's a rate growth of about 4% over FY 2021, including an additional $25.6 million to expand services. And I talked to members in our DD community yesterday in some of our facilities, and they really have been, as many organizations have been, extremely flexible in transitioning into a virtual online, and then reaching out and wrapping services around more individual attention for many of our population who struggle with developmental disabilities. There was an additional about 124 million that'll cover provider rate increases, particularly to the fields of behavioral health, developmental disabilities, and other healthcare services, and 41 million to implement the rate increase that was introduced early this year. And that has been so very important as we go forward to move our services into the community with the wraparound that's necessary. 62 million fully funds the local health grant formula, along with the new block grant program to increase funding for our local health departments. Our local health departments have just been champions when it's come to testing, to implementing and getting the vaccine out there, and to coordinate services and to participate in just the COVID teams on the ground to be able to assist businesses in knowing how to set up the protocol and how to make decisions when and through the contact tracing that takes place. So I want to say kudos to all of our public health people and health providers around the state who've been working so hard. Your focus and your engagement of the public has been, again, vital, because in times of high anxiety, we want to make sure that there's predictability, that there's reasonable expectations and support as needed. The budget also includes about 1.8 million to expand the program of all-inclusive care for the elderly, or our PACE programs that allow seniors to remain in home and community settings. And more, it's really going to be important to sustain people in their homes, to be able to promote independence, and to keep folks to boost self-esteem at the same time, because you're never too old to learn new things and to practice new behavior. So any kind of support to be able to keep that anxiety that folks may be experiencing channeled will be pretty critical in the prevention of further deterioration and the beginning of depression and some of that disturbed thinking that contributes to thoughts of suicide. Next slide, please. In order to combat the ongoing silent epidemic of opiate abuse, and that has been here all along, we know that alcohol use and abuse and substances continues to be high in spite of the pandemic. In fact, in some cases more so. And the Hogan administration has also provided record funding, 978 million for substance abuse treatment. And we're really thankful for that, and thankful that the programs are up and running. We have some new programs to be able to provide some 28-day treatment that we know is so important to be able to interrupt those negative thinking and interrupt those behaviors, to be able to get folks clean and sober and on the right track, or get folks into medication-assisted treatment so that we can begin to improve that thinking and functioning. The budget includes about 296 million for substance use disorder services, which is a 35 million increase over FY21, and 231.8 million for our mental health and substance use disorder treatment for uninsured Marylanders. It's another record high investment. We know many of the folks who are homeless on our street also suffer from mental illness or substance use and abuse. And as we can improve our services for our homeless, we're also able to get people into an evaluation opportunity where they can further meet their needs and determine what is going to be beneficial to wrap those services around folks. Budget includes more than 10 million to fund the activities of the Opioid Operational Command Center. And this is the 5th installment of funding it for a total investment of more than 50 million. Again, Because the governor set up that command center in the beginning a number of years ago, we already had a network in place that's kind of based on emergency response. And that network was actually, I think, the backbone for how we could deal with the COVID pandemic in a very realistic way with our on the ground folks in our communities. Next slide, please. So I know that's quick and dirty of what's going on in Annapolis, but I just wanted to let you know that we do hear and are concerned. Many of our legislators are so concerned about the needs of our seniors and about the needs of all of our families. And we want to make sure that we're making the right policy decisions that will facilitate and enable you all to continue to be the on the ground folks to provide that wonderful support and structure and early intervention to prevent suicide and keep people healthy at home. Thank you.
Thank you, Senator Eckardt. That was a really great update. We appreciate you joining us and providing that type of update. It's really nice to see that, especially during the pandemic, that there are these resources and these legislative actions occurring. We're going to open it up to questions right now for Senator Eckardt. You can type them into the chat box if you'd like, and I can read them for you. If you wanted to take yourself off mute and ask a question, feel free to do that as well.
No questions? Somebody must have one out there. Did I go too fast? It's early.
Good morning.
It's early. There we go.
Hi,
Go ahead.
My name is Secundayo Akinola. Thank you very much, Senator. Everything you put on the screen was interesting. But my area of interest mostly is, because I was trying to write it down, but I couldn't do it, but is the provision for seniors or elderly to be able to remain in their own home, what we usually call age in place. It's very difficult to access because never know where to call in Maryland, to be honest, when you want to deal with aging population, what services can they get, how can you access them?
Sure.
Where do we need to call? I know there is aging department, as it's called, but it's difficult.
Yes.
If you dial 211, you will be on your bed. You will still waiting for somebody to respond.
So is the 211 press one not responding?
They'll be singing in your ear for the rest of the day. And if some of the recorded answer, it will be press this, press that. It goes on and on and on and on. As we know, aging population, I'm so glad that they're focusing mental health and all those situations. It's frustrating to tell people press one, press this, press that, and can never get to the service they need.
Thank you for that feedback, because my understanding was, I know there are 211 centers throughout the state, and my understanding was that they are set up with individuals to respond those. So I will take that back, because I agree with you. I get frustrated when I have pressed this and then you get a recorded message, press that, you get another recorded message. What people do need is they need a warm voice on the other end of the phone,
Yes,
be able to sort out the information and then make the recommendation. So we will take that back, because that is really important. And I think we could probably put in the chat, there are some other services available as well. But my understanding is they're mostly phone calls that have a programmed response. So we can get that information and get that back to you.
Thank you, Senator. Appreciate
Good
that.
question. Good question. And I'm sorry, I did not know it was working. My understanding was that I know at least on the Eastern Shore, it goes into a central office because I've been to that office and I've seen the people behind the phone. So
Mhm.
that's why thank you.
Yeah, I got a call from somebody who needed the help, and I personally take it to myself to try it, and I
Sure.
was frustrated.
Good.
So I'm so glad that I can put this on the table.
Yes, we will look into that. Thank you.
Yes, ma'am.
Thank you. We have a question in the chat box. Someone is wondering whether Maryland will continue to respond after COVID has exited. Let's see, it's written to me as, will Maryland respond continue after COVID?
Hi, this is, can you hear me? This is Lee,
Hi,
Newcomb
Lee.
with Talbot Social Services. No,
Hey,
the
Lee.
Maryland Response Program, that I don't know a lot about it, but I feel like it came about as a COVID response. It was supposed to be like an emergency response for when caregivers are not well or something to help fill in. But there's also been other programs, I mean, like the call check program from the Department of Aging has expanded since this. So I'm just wondering if these things are going to continue or if we can expand on some of these programs that have come about as a result of COVID or have taken off maybe as a result of COVID. Is there any kind of talk about that?
I do know that through the Department of Aging, they want to expand those because we recognize, and I know the Secretary of Aging because she has a number of programs in place where we're trying to wrap, and I think Talbot County is one of the lead agencies on that, and I'm trying to remember the name of it. Lee, maybe you know.
It was Maryland Community for Life.
Maryland Community for Life, yeah.
Right, the Maryland Community for Life programs is a statewide, and there's certain counties that have received the grant funding for that, and Talbot was one of the counties that has that. It's now
Correct.
merged
And
with Partners in Care.
right, and that combination of Partners in Care and then Communities for Life is anticipated to be expanded, but the call check as well, so that everybody, if they choose to be in their home, has access to the kind of supportive services and beyond that to the extent possible. So yes, if you look at the very foundation and the philosophy behind that, that's the way to be able to provide these services, whether you have a supportive family network in place or not. And it has been a real lifeline, if you will, to many folks. So these are all the kinds of activities that will be my understanding is we're going to try to extend a number of those because the pandemic has pointed up the need in a more profound way.
Great, thank you.
Does anyone else have any questions? I don't see anything coming in the chat box.
I have another question that was sent, and it reads, are there any programs being developed to assist seniors with access to telehealth services for mental health? Many seniors either have no internet access or are unable to navigate the technological processes necessary to use telehealth.
Good question. If you don't have electricity coming to your house, the lights don't go on, correct? And we have many, many communities who still do not have fiber to their homes to be able to get access to the internet. They're dependent on phones and hotspots that are very inconsistent or non-existent. So the other crusade that I've been on for quite a time, because in Dorchester County, if you go down to Bishop's Ed, you can't get access. And so we have been working with the governor. In fact, the Senate just added another 5 million to broadband deployment. To the governor's some 20 million. We'd like to find another 5. And that would provide that kind of last mile coverage to most people. Now it's going to take probably 3 or 4 years to get everybody connected, But yes, that's a vital need to be able to have that infrastructure. In addition to that, there were some grants that just went out through our core service agencies to be able to provide funding for devices and then be able to get that kind of tech help. I know I've had to just employ somebody regularly because I am not a whiz kid. I'm too old, and all of our grandchildren can do this, walking, and, they are just so good at this. So I have to call the kids to help me do this. But it is important that we do have that kind of technical assistance because, we know there's danger out there too in the cyber world. And we want to make sure that people have access to tablets or to a phone and know how to use it. So I think that's going to almost be a part of the services that we provide. Whether you're in, somebody said that tablets have been in the nursing homes to be able to get the virtual visits. And, we will be extending those kind of services. Yes.
Emily, did that answer your question? Emily adds, my patients are in assisted living facility and they're not allowed to have young people or their children come in because it's restricted. And they have the internet, but they don't know how to use it, was just her additional point.
That's really interesting because there was some research that was going to be done, and part of the research project was to go in and be able to be in nursing homes and assisted living programs and bring folks a tablet and show them, support them in how to use it. I know that got interrupted with the pandemic, but you are exactly right. It's important that we are able to expand the devices, expand the services. And we have a bill called Digital Inclusion Act of 2021. And these are the very issues that we're looking at because we've learned how essential it is that you do have an adequate way of communicating. I mean, texting has become so very important to us in Annapolis because we can text and be on the Zoom meetings at the same time, but we're all using multiple devices. We thought one laptop would be fine, but I'm sitting here with a laptop and a monitor and an iPad and a phone to be able to get all the information I need. So you're exactly right that this is part of what we're going to, I think all of us, including in our practice and our delivery of care.
Okay, we have another comment from S. Smith, and this person writes that additionally, many low-income seniors use cell phone service through the government programs, and the amount of data available is extremely limited. Often the client uses all of their monthly data allotment for a single telehealth therapy session. What can be done with that?
That's part of the discussion that we're having now with carriers to see how, and I know they extended some of that during the COVID, the beginning of the crisis. So I think now that we're in session, this is a part of the adequacy of that. And then what mechanism can be put in place if in fact somebody has exhausted their data on a visit, and then how can that be reestablished? Very good concerns and things that we have kicked around. So thank you for reinforcing that.
And then we have just a couple of comments about the importance of
testing the system. Yes, you're exactly right, because we need that kind of feedback, because why do we keep putting money into something if it's not working? We need to know that ASAP. So never hesitate to call us. Most of us give out our phones anymore. just because it's easier to respond to people on your own time schedule. And or email our office. All of our staff have been working diligently with constituent concerns, with unemployment concerns, and we know the frustration with the unemployment concerns and being able to navigate the phones. You know, all of us struggle with that on how do we improve access to services, and the tech services are exactly an important piece of it, because we know that it's that other person, warm body interaction that we don't want to lose with the mechanisms.
Emily Metzger would like to know what resources are available to use now, where they can call.
Again, was that, you know, what we, you know, basically, I think if you go out on the internet for emergency services, crisis services vary from community to community. And we talked about the 911, we know 911 is emergency call, and that's what the anticipated 211 was, get help, to be able to find out, you know, more specifically, to point people in the right direction. So that was the intent of that. You know, when there is an emergency, 911, of course, if it's life-threatening. But if you are familiar, and just look up on the Maryland Department of Health, if you Google and you're in a place where you can Google, Google's an invaluable resource, I have found. You know, I grew up with the encyclopedias and look it up. And, you know, Google to me is much better than that, because it gives you a variety of services and the phone number. And many times you can just click on the phone number and call as well.
Okay, well, thank you very much. We appreciate that. If people want to continue asking questions in the chat box, we can certainly address those later. And what we'll do, if Senator Eckardt cannot stay on, we will compile those questions and send them to her.
Oh, that would be great.
And send them back.
And my email's in there as well. So don't hesitate to email, because our staff is very responsive. And when they're not working in the office, they're working virtually too. So thank you all very much for the opportunity. And I will certainly get back to you with a menu of resources. Most communities have directories for where to go to. Never forget that our libraries are all available, and they have resources online as well. The Sailor Network has been one that's built out, and then we have our core service agencies, and they are our mental health authorities, behavioral health authorities, and every community has at least one of those. Thank you.
Well, thank you. We really appreciate your time and spending part of your morning with us to update. It's really nice to see the responses again from the state related to the pandemic to address these mental health and well-being issues, specifically as they relate to older adults. A public survey from August, this past August in 2020, illustrated that 24% of adults, so I said early on that about 20% of older adults have suffer from depression. That's not any different than the general population. But the survey from August, which was a nationwide survey, illustrated that 24% of adults 65 and older have experienced a negative mental health or a mental health crisis as a result of COVID. So it's nice to see Maryland beginning to respond to that. And I know with telehealth and some of the services that are going to be available. The greatest risk is to persons that are in fair or poor health, as well as people who are socially isolated. I think it's 37% of people who are socially isolated reported a mental health crisis, and nearly half of people who reported being in poor or fair health reported also a mental health crisis. So these resources are going to be really important for the providers to really be able to serve them better. Information from our next speaker, Kim Burton, is going to address that a little bit more deeply. She's going to help us to understand why these folks are at greater risk. And between her discussion and later with Ms. Richard, will get access to some services and so forth. So let me now introduce Kim Burton. She is recently retired from her position as the Director of Older Adult Programs for the Mental Health Association of Maryland, where she led education and advocacy activities for the past 20 years. Kim has developed curricula related to workforce training, authored a celebrated guidebook on mental health and aging, and delivered hundreds of public and professional education and training events across the state of Maryland. Kim received her bachelor's degree in human services from George Washington University and promptly began her career working in nursing home, where she developed a deep passion for mental wellness of nursing home residents. In 1990, she pursued her certification as a geriatric mental health specialist from the University of Washington and went on to work as part of the multidisciplinary team delivering mental health support and services in several Seattle-based nursing homes. She moved to Maryland in 1995 and developed and implemented a gatekeeper program through Senior Network of North Baltimore, whereby local businesses and organizations receive training on the identification of at-risk older adults and resources to support aging in place. Kim's work has been recognized with awards from the Maryland Gerontological Association, and she is often sought as an educator on issues spanning late life mental wellness strategies, mental illness, cognitive impairment, substance use disorders, caregiver stress, peer support, and workforce development. For 20 years, Kim has chaired the Maryland Coalition on Mental Health and Aging and played a leadership role in the Maryland Senior Citizens Action Network, supporting legislation to benefit the health and housing needs of low-income older Marylanders. She has served on the Executive Committee for National Coalition of Mental Health and Aging, the Governor's Commission on Disabilities, and the Governor's Commission on Suicide Prevention. Currently, she is volunteering her time in organizing committee of Baltimore Neighbors Network, a Baltimore City-based initiative to provide social and mental health support to older city residents. Welcome, Ms. Burton.
Thank you, Diane. I know that you can hear me and can't see me. I've tried to start my video and I'm actually kind of excited that you can't see me. But it says that the host has control over that. So I wanted to let you know that.
Kim, I can show your face if you'd like me to.
I would be happy for you not to show my face.
Okay. However you'd like it to be.
That's great. No, that's great. Actually, it's so distracting.
Okay.
Thank you. Thank you. And thanks to Senator Eckardt for her information and also for being a champion on all issues of aging and behavioral health. We are so grateful to have her on our side. I also want to thank Diane and her colleagues at GGEAR and at the Central Area Health Education Center. You guys have worked very hard on this, and already I think people have been able to take away a lot of really important information. For those of you in the audience today, so to speak, I want to acknowledge your expertise. We have a lot of people who have professional experience as well as lived experience with suicide, and I would encourage you to share your thoughts and definitely resources in the chat as we go through the day. I'm looking forward to hearing from you and getting your feedback and input at the end of the day when we will be having a question and answer session. So quickly, I want to run through the objectives. Before I begin, though, I want to reiterate the sensitivity of this issue. Many of us know people have died of suicide or attempted suicide, or maybe we felt suicidal ourselves. And sometimes digging into topics like this can stir memories and trigger emotions. And so if you feel uncomfortable or distressed, or that you want to talk to somebody and just get some help today during this presentation or anytime today, please dial 211, press 1, which is our most reliable hotline right now for supporting people who are experiencing mental distress. Our objectives are to distinguish between contemplation of mortality and suicide ideation, to describe the unique mental health issues, needs, and challenges that elevate risk for suicide in older adults, and to recognize the warning signs of suicide in older adults, and to identify barriers to the identification, assessment, and treatment of late life mental health problems. So next slide. I don't like to use the word normal, but we use that word often. So I'm titling this slide normative and want us to think of normal as just a setting on the dryer, because we're all very, very different. And we need to acknowledge the diversity of all older adults and not lump them into one category. But as we will explore more in depth, we experience a lot of change if we get to live long enough. That's inevitable. Change is normal. It's also more common in later life that changes aren't necessarily chosen or desirable, and often they represent loss that may be physical or social or financial. Some changes are chosen, and some changes are chosen and made for all the right reasons. For example, if somebody chooses to live in a new residence, and they can be wonderfully excited about that, but there still is some loss and some grief that's behind that. So we need to acknowledge that. It's normative that older adults are witnessing change and loss among their peer group. And as they witness the experiences of their peers, of course, they wonder about their own future and their destination. So most of us are living a mystery, and we don't have a crystal ball to show us the future or what the end of our lives are going to be like. Yet this is a time when we ask people to make decisions about life's end that they may or may not have contemplated before. And for some of this can be anxiety provoking, and for some of this, it might bring some comfort. So if you can just click 2 times, I have 2 images I want to show here to kind of bring this more to life. It is really common for older adults to be getting mailings from funeral homes that are messaging to them that they should be thinking about making preparations for their own funeral. We're also urging people, and rightly so, from our health and human service professionals, we are telling people about the importance of preparing for when they can't make decisions, like getting things in order, such as living wills or power of attorney. And here I have a little snapshot from the website about the MOLST, which is the Maryland Medical Orders for Life-Sustaining Treatment. And we want people to be thinking about these kinds of decisions that they want to be making. But this is usually something that people are doing more often later in life. I begin with this slide because I think it's really important to differentiate normative end-of-life thinking from suicidal thinking. Thinking about death, being prepared for death, even expressing a readiness for death is not the same thing as being suicidal. Suicidal thinking is most often a symptom of depression or another mental health problem, and misery, whereby somebody feels that the only way to escape pain is to end their life. And we could right here have a day-long conversation about an individual's right to die as described in the Death with Dignity legislation or other similar movements. And I want to take that off the table today for the purposes of our discussion here, because I really want to focus on the suicidal ideas that come from mental health disorders, of which most are treatable. When a suicidal person is properly treated for their mental health disorders, we find overwhelmingly that that person loses the desire to kill themselves. And we should never be in a position where we have to make a decision about someone's mental health or the risk that they are experiencing in terms of suicide. That is why we want to make sure that we involve mental health professionals when we can. And I urge you to always encourage people to seek mental health support. And if you haven't already, I want you to know about mental health first aid. which is available through the Mental Health Association of Maryland. And mental health first aid is designed to help lay people feel more comfortable in talking about mental health issues and intervening when necessary. So this montage of pictures right here, I chose these off our Google Images to picture some changes in circumstances and struggles that are more common in later life. Again, these can happen at any time in life, but in later life, we seem to see a bunch of these kind of pile up. So what you can see are individuals that are challenged by difficulty sleeping, financial constraints, loneliness. We see here people that are struggling with health problems, functional problems, mobility, and perhaps cognitive changes. And in this time when things are changing rapidly, we are asking people to navigate new technologies and systems like our healthcare system, transportation, medication regimes, all of this at a time when cognitive changes can just really exacerbate frustration and confusion and other forms of distress. I know for me, I have a hard time understanding the bills that I get in the mail, especially health information. And I'm always wondering, are they asking me to pay this money? Are they giving me this money back? So we have to understand that there are a lot of systems that we are asking older adults to navigate at this time. So looking at this overall, you know, who has these kinds of things happening to them? And next slide. The answer is we do. We have these things happening to us, all of us. If we're lucky to live long enough, there's no question that we're going to face changes and challenges in all of these realms of our lives, and these realms being physical, social, mental, emotional, spiritual, environmental. All of these things we will experience changes, and this is not a bad thing. In no way do I want you to think that I'm suggesting that aging is a downhill experience. Societal messages have been pretty consistent about branding old age as something that's bad. And there is nothing bad about aging. We're all doing it right now. The stigma of everything going downhill is just that, it's stigma. What's true is that there are going to be lots of changes and challenges, but you know what? When surveyed, overwhelmingly, older adults will tell you that they are more contented in this period of their life than in earlier times of their life. But the other true thing is that changes can be stressful. And if multiple stressors are present, there are greater risks that the brain can be affected with distress that turns into depression or anxiety. And so what we're going to do now is, if you can do another click, we're going to do an exercise, a brainstorming exercise, and you all will be invited to join a breakout room. I want you to take about 5 minutes to think about common late life experiences that are also risk factors for suicide. Again, common experiences that are also risk factors or raise the risk for suicide in later life. So within these realms, get together, do this brainstorm, and we'll all come back together in about 5 or 6 minutes. So thanks everyone for coming back. And before we talk about the exercise that we just went through, I want to revisit something that I said earlier. Earlier, the slide said, "This is us." And I meant that we are all going to be experiencing changes as we age that might be challenging. If, as a society, we acknowledge that all of us will experience change and that many of these changes will be challenging, then we should be taking what's called a whole population approach to suicide risk. And that's what this slide is about. our systems and programs should build in protection against suicide, just with the understanding that the whole population is potentially at risk just by nature of the kinds of changes that people are going through. And we'll get to those later. But I want to show you this model to emphasize that by taking this approach, that assumes that we should prepare and support all older adults. And then we're likely to lower suicide risk. But we also have to be involved with people who are at risk, be able to acknowledge them, identify them, support their needs. Excuse me. And then in doing so, we will reduce the number of people who are in crisis. So population approach is something that I'm going to be referring to a couple of times, but now I want to revisit your brainstorming activity. And because we have such a large group in this webinar, I'm going to ask you that you use the reaction option. Hopefully you have that button available where you can raise your hand or even clap if you want. And I would like for you to do that as I go down the next two slides where the common late life risk factors are specified. And I'm going to go kind of slow so that you have time to raise and lower your hand. But what I want you to do is raise your hand, excuse me, if this is a late life experience that you identified as a risk factor. All right, so the first would be conditions that significantly limit function or life expectancy, or conditions that cause pain. Raise your hand or give a clap if you came up with that one. Cognitive impairment, and the reason cognitive impairment pertains in, as we talk about suicide, is the loss of judgment and also increase in impulsivity. Another one is the anticipation of pain or the progression of illness. So somebody who's got a condition and they think it's only going to get worse. Another one is a perceived burden on other people or actual dependence on other people and not wanting to be that. Certainly compounded losses, bereavement, grief. You know, grief is not depression. Bereavement is not depression. They are two different things. But unfortunately, there are people who will experience depression and say that that depression is grief or bereavement. It's pretty complicated, and that's why we just want people to be talking to health professionals that can help them with the difference of that. A huge risk factor is a perceived loss of purpose, usefulness, and relevant role in the family or in society, among friends. Next slide, please. So next slide. Risk factors are depression or major depression, conditions with pain and functional decline. So people who are not able to do those things that they used to be able to do and that they want to do. Another risk factor is the use of substances. And I have on the slide, which I'm hoping that, oh, there it is. I'm sorry. It doesn't have to be misuse, abuse, or addiction to be risky. Just simply the use of medications or alcohol in a way that people think are appropriate may not be, because of metabolic changes and other changes that happen to us as we get older, that then make it so much more, make us more vulnerable to side effects, to toxicity, and to negative effects of anything we might put in our body. And that includes over-the-counter products as well. Another risk factor, anxiety, agitation, rage, revenge, feelings of just anger around the circumstances. Diane brought this up earlier, or maybe it was Senator Eckardt, but I think probably everybody is aware that social isolation can be really problematic and lead to loneliness. So withdrawal from other people and withdrawal from activities. These are things that might be consequences of late life changes that also present as risk factors, loneliness especially, and other major life changes and losses. So we may not be thinking about this, but it was brought up a little bit earlier, pets. So somebody might get an assessment for mental health and they find no mental health problem, no depression or no anxiety. And then the next week they lose their beloved pet of 5 years, 20 years. And this is a major change, a major loss. So we want to be vigilant to big changes and suggest during those times of big changes that people keep an eye on what might be happening. So these are risk factors. And now I'm going to flip to some warning signs for suicide. One is family conflict. So oftentimes people when they're experiencing these changes and they have feelings about this, it can cause some rifts in relationships, in families, with friends, but that's something that can be a warning sign. Anybody who has attempted suicide earlier is somebody who is at greater risk for suicide now. Same with somebody who has a family history, or people who have lost good friends to suicide. So this is something that we should know about. And while it may not show up necessarily as a sign, it's something that we want to know about because it exacerbates the risk. Listen for expressions of no sense of purpose or meaning in life. Certainly, if somebody is seeking access to firearms, pills, or other means to achieve death, this is something that is a huge red flag. If they have access to the means for suicide, we want to know that too. Older adults use very lethal means because their intent for suicide is usually pretty, I'm going to use the word again, intentional. That's what they want. And so they seek the most lethal of means. Next slide, please. Talking about wanting or threatening to hurt or kill oneself. Absolutely. Warning sign. Don't ignore that. Talking or writing about death when doing so is completely out of character. Now, again, I want to kind of harken back to our discussion about normative thinking and writing and talking about end of life. There is a difference, and the difference is usually in the tone. And for individuals who are feeling suicidal, who are most often depressed, when they are writing about death or talking about death and they're feeling suicidal, you're going to hear a different kind of tone. You're going to hear somebody who is expressing feelings of misery, feelings of burden. Instead of saying, I am ready for the Lord to take me, you will hear them say something like, why doesn't God just take me now? All right, so these are, you just want to listen very carefully to the words and the tone and the meaning underneath the words that they use. Getting affairs in order and giving things away. Again, this is something that they're going to likely normally do. That's what we might think about as we're getting older and thinking, oh, I would love for my granddaughter to have the dining room set. I would love for her to have our family table. And that's different than somebody who's taking their wedding rings off their finger, placing it in the hand of a loved one and saying, I really want you to have these. So we want to look at what kind of things they're getting in order and what kinds of things they might be giving away. Also want to look at reckless or risky behavior. So if somebody seems to be having accidents more frequently, that is a red flag, and I'll talk about that in a minute. But this last warning sign is something that few people know about. Individuals who have decided that their escape from pain is suicide may have a sudden burst of energy, an elevated sense of peace. It can look like somebody who was depressed before is suddenly not depressed anymore. And that is not what's happening. What's happening is a sense of relief and energy that comes from having made a decision about getting out of pain. So whenever you see that warning sign, please be very, very vigilant and talk to the individual about that change. When you see warning signs, we're not asking anybody or expecting anybody to be making any kind of clinical assessments or decisions. When you see warning signs, we want you to feel comfortable talking with the person, and we'll get more into that later, but talking to the person about what you're observing, so that when you engage them in conversation, you might reveal a little bit more of what their actual intent is, how they're really feeling. I'm going to show you a couple of slides that I think are pretty amazing. This is the ratio of suicide deaths relative to the number of attempts that are made. These are statistics that are gathered by the American Association of Suicidology. This is from 2015. And this is looking at adolescents. So what they found is that among adolescents, there would be an average of 1 death for every 100 adolescents who make a suicide attempt. So 1 death that comes from 100 attempts. Next slide, please. So if you apply that same ratio to the averages of all ages combined, young people through old people, that ratio is 1 death for every 25 suicide attempts. And now get ready for the next slide ratio about older adults. There's an average of 1 death for every 4 people who attempt suicide. I want you to just sit with that for a minute. That is a stunning number. So why do you think the ratio among older adults is like this? I'm going to talk now about higher completion rates. Older adults have higher completion rates because their plan is more likely to be thought out versus impulsive. I did mention impulsivity with regards to cognitive impairment, but for the most part, older adults have been thinking about this, and this is something that they want to do, and hence their plans are less likely to be revealed or discovered. There's less likelihood of discovery or rescue after the incident, after the attempt that is fatal. They're often less likely to recover from attempt simply by virtue of the fact that we don't have the same resources to bounce back from insults and injuries to our body. As I said, they use more lethal means. And then I want to go to the next slide, which talks about the passive methods. Let's see here. For the next slide, I want to talk about passive or indirect suicide. And this is something that Senator Eckardt was referring to with some of the legislation that she was referring to having to do with forensics. We know that older adults have high rates of suicide because the Centers for Disease Control gives us the numbers of people who have died from suicide. And we know they've died from suicide because that's what it says on their death certificate. But there are plenty of people whose death certificate says something like heart attack, something that would not indicate suicide. Passive suicide is something that occurs over time can reasonably expected to result in death. So it's a choice or it's a behavior that somebody makes knowing that the consequences of that behavior can or will end in death. And so that would include things like refusing food, refusing necessary medications, not taking care of oneself, self-neglect, and risk-taking behavior, which I mentioned a little bit earlier. So if I know that driving without my glasses is dangerous, but I don't want to be here, I might be driving without my glasses. Taking risks like that, maybe walking through a crosswalk when I don't know that I know that I don't have enough time to make it across, those kinds of things. And therefore the death would be ruled as a car accident, when in fact it was really the person who put themselves in harm's way. Next slide. With our eyes open to risk factors, warning signs, and information about the higher suicide rates among older adults that we've been talking about, I think we need to challenge the traditional script that we have, which is, if somebody is so miserable, why don't they say something? It's not easy. We can come up with many reasons why people don't say something, but I think what we're doing is expecting that verbally something is going to come out of their mouth that we shouldn't necessarily expect that they are prepared to say, or that they even understand about themselves. They may not be able to voice their misery, but their misery might be showing up in other ways. So in this picture here, I've got a picture of a man who's looking like he's pretty angry or grumpy, more than grumpy. He's up and saying something about something that's irritating him. And one of the signs of depression in later life is agitation, anger. They have an edge. They are testy. If you ask people to draw what does depression look like, oftentimes they draw a sad face with tears, but that might not be what depression looks like in an older person. So what we're looking for is a change in somebody's behavior. And if this is a man who in the past was not at all confrontational, who was very easygoing, and now we see him behaving in ways that are uncharacteristic, we need to acknowledge that. We need to take that as a sign that we should be talking to that person. Click again, please. In this picture here, I love this photograph for how intensely it shows the depth of this man's pain. So we know that people are experiencing losses, and huge losses for some people. This is a guy who grew up in a time when expressing his emotions and expressing his pain was not encouraged. We might be expecting people to be telling us and showing us things that they were cultured not to tell us or not to show us. But we should imagine that if somebody is going through grief or loss, that this might be how they're feeling on the inside and not necessarily what they're showing on the outside. So I want to tell you, in my work at a nursing home, one of my jobs was to make people feel really welcome when they entered the nursing home. And that felt disingenuous to a point. Yes, we are glad you're here. We are happy that you're joining our family here at this place. But we also want to acknowledge that you are probably grieving the loss of many things. When people leave their homes, many things are left behind, and it's normal to feel that way. So we need to be having conversations with people about the grief, instead of thinking that we need to wait for them to show us that grief before we have those conversations. Next click, please. So we have a lot of older adults, as Diane said earlier, who are going to their doctor within a short period of time that they decide to take their own lives. And too often when people go to the doctor and they are presenting with symptoms of depression that are physical, and let me say that when older adults are experiencing a mental health problem, a mental illness, they feel it very physically. It might be headaches, it might be tension, it might be stomach pain, gut problems. And so when they're going to the doctor, typically the conversation is about the symptoms that they're having. You know, what is going on with your stomach? So in this picture here, I'm imagining this woman going to the doctor and she's got aches and pains that don't necessarily have explanations, but he's prescribing some kind of medication because that's what we're really good at doing here in the United States, is finding a pill for symptoms. What needs to be happening in this kind of situation is that the older person needs to be asked questions, and this doesn't have to happen in a doctor's office. This happens with all of us who are professionals, and when we're interacting with an older person and they're talking about health problems or physical complaints. It's important for us to say something. It's important for us to ask, have you experienced any changes recently or any losses recently? Or tell me what it's like when you wake up in the morning. What are some of the things that you look forward to doing? And by asking these kinds of open-ended questions, we will hear from them what their life experience is like. And if they talk about feeling like they don't have a purpose, that they don't, they've got problems within their family and they're feeling like a burden, these again are indicators that perhaps they are feeling suicidal. And whether we call it quote unquote depression or not is really not as relevant. What's important is the distress that they are experiencing. So if you click again, what I want us to do is ask why we don't say something. Being aware of all of these kinds of issues and circumstances and changes that we've been talking about thus far today should make us aware of the fact that we need to say something. Next slide, please. So the far left column here is the birth year. And then to the right of that is the age of a person who was born in that birth year. And the fastest growing segment of our population right now are people who were born before 1950. So I want you to ask you to think about what people knew about mental health problems before 1950. And you can see there that I've made a note that it wasn't until 1949 that the National Institute of Mental Health was established. So we really didn't know about mental health issues, symptoms, circumstances, causes, or any of these things for a very long time. I don't know if you can hear my cat meowing in the background. I apologize for that. But when we talk about culture, we're not often thinking about a culture of age. And you know, maybe we do with younger folks, with millennials, we might think, oh, they're a culture that has been raised on technology and is good with technology. The cat's not going to stop meowing until I open the door. Hold on one sec. Sorry, that's what happens. That's what happens when we're working from home. Sorry about that. So for the purpose of today's topic, I want you to think about what older adults grew up knowing about mental health. You know, what were they taught? And understand that there's a lot of stigma. Stigma is the disapproval of or discrimination against a person based on perceivable characteristics or circumstances that serve to distinguish them from other members of society. I'm going to read that again. This is a statement about stigma. Stigma is the disapproval of or discrimination against a person based on perceivable characteristics or circumstances that serve to distinguish them from other members of society. Stigma is very acute around mental health among older adults. And I know I'm making a sweeping generalization, but we know this to be true in general among older adults. The other kind of stigma that they're experiencing is just the stigma that comes with aging. I think it's safe to say that most older adults don't know or don't want to know or are not even aware that they need to know their risk for mental health problems in later life. And we need to have conversations with them. That's definitely the whole population approach. But we have to be careful about how we do this. And so I want to talk a little bit about language. If an older person is confronted with somebody saying that they believe they have a mental illness, we need to understand that that may be something that is offensive to that person because of the stigma that that term carries. So if we take what we've been talking about with regard to the culture of aging, then we can come up with some ways that we can make mental disorders more palatable. So in this case, instead of saying mental illness and talking to somebody about having a mental illness, which might trigger them to think about stigma, we'll have more success if we use their language or if we use terms that are more widely known for, distress. I can see you're under distress. I hear you say that you're feeling low. And we will get agreement from them when we are using the words that they use to describe how they are feeling. So that's one thing I want to say about the culture of aging. The other thing I want to say, or culture of language, I'm sorry. The other thing I want to say about the culture of language is we talk in a way that is not helpful when we talk about suicide. We need to be very sensitive to the language we use when we're talking about suicide. And the word committed is used when someone commits a crime or commits adultery or commits a murder or commits a sin. So what we're insinuating when we say that word commit is that that person is doing something that is horribly bad, instead of honoring that suicide is something that is born of an illness and a disease with symptoms that actually robs people of their life. So we don't want to say commit suicide. We want to say died from suicide, died by suicide. Similarly, we never want to say successful suicide or unsuccessful attempt, because when we say that, then we are giving the impression that suicide should be an achievement. And so instead of saying a successful suicide attempt, we don't call it a successful attempt. It was a suicide death. We don't say an unsuccessful attempt. We call that simply a suicide attempt. Our language is really important. All right, I want to shift now to another area that I want to explore with you in terms of being sensitive to older adults and the culture of aging. We need to be providing education. Remember the stigma. Remember the fact that they grow up in a time when they did not know very much about why mental health problems occurred and what they were about. And we know so much more now. And I have found it incredibly powerful in talking to groups of older adults. Really, you see a shift in their acceptance of discussion of mental health when you help them understand that mental health is about the brain, and that everybody has this brain, this organ of our body, that is susceptible to illness just like any other organ of our body. And so in talking to them, we let them know that what contributes to their brain health is personal health practices, the environment that they're in, the levels of stress that they're under, and that there's even a genetic component to brain health. And then there's inherent nature. Some of us are more sensitive than others, and things hit us in a different way that affect us differently, such that we might be more distressed by a circumstance than another person. That's not right or wrong. That's just different, and we're all different. And once people begin to understand and accept that brain health is what we're talking about here, then I delve a little bit deeper. So those 3 little pictures at the bottom, if you can put those up, I talked to them about literally the physiology, the neurobiology, and we can't get too complicated because these are terms, I mean, I don't even remember all of these terms, but what we can say is that in our brains, we have billions of nerve cells, of brain cells, of neurons. So these things are called neurons, and neurons need to communicate with each other. And it's really important for these neurons to communicate for us to feel our whole health and for our brain to be working as well as it needs to. But sometimes the neurons aren't transmitting the certain chemicals that they need to be transmitting. I mean, however you want to put it, but I find that visuals are very helpful to help people understand that the transmission of neurotransmitters can be impacted by medications. Okay, so those little dots that need to communicate from one cell to another, that can be impacted by by medication, by alcohol. So these are the ways that we want to be talking to older adults, keeping it on a very physical level. The next slide, please. This is a statement that comes from literature that reinforces the need for education, beginning with healthy aging to the broad population. So here it said, the objectives of education programs should be to foster an appreciation of healthy aging, improve understanding of signs and symptoms of depression, and to teach about risks, warning signs, and treatment responsiveness. This is the whole population approach I was talking about earlier. This is something that we should naturally be doing for older adults instead of waiting until they are deep into the risk factors or experiencing a crisis. So this moves us into the territory of talking about solutions, or at least more about a whole population approach. And the next couple of slides list some other things that can be done that would be considered protective factors against suicide. So let's spend a little bit of time with this. These actually came from the National Strategy for Suicide Prevention. And here are things that are protective that we can encourage people to do or help them to do. Number one, they need to be getting clinical care for mental and physical needs. They need to be seeing a professional. Number two, we need to have easy access to interventions and support. And we do not have a system that is very easily accessible. In fact, it's very difficult for a lot of people to understand because we've been having 2 separate kinds of health systems for people, one for the body and one for the head. So we need to provide a lot of education and information about how it is that people can get support for distress. Strong connections to family and strong community support are very protective against suicide. So as we see people who might be losing family members, might be losing friends, might not be engaging with their community as they used to, because maybe they don't drive anymore. Driving is a big red flag for people to experience a lot of distress. And that's something simply losing a driver's license can remove people from their communities of support. This is hugely impactful, and we need to be vigilant to that. Meaningful engagement in activities and community. It's not enough to just tell somebody where the bingo game is, all right? It's not just about inserting people into things that keep them busy. Engagement, activities, they need to be meaningful to the person. I hesitate to tell you this now, but my cat has a bird in his mouth. So I'm going to close the door. Hold on. Oh my glory. Sorry for that interruption. Where are we? Protective factors against suicide. So cultural and religious beliefs that support self-preservation, that can be something that is helpful to an individual in terms of protecting them against risk for suicide. And then personal characteristics. You know, we're all different, as I said before. We've got different personalities and different temperaments. And what we find is that people who are more resilient and flexible, people who have positive coping skills and help-seeking behavior are people that are more protected against suicide. People who are very rigid in their thinking and rigid in their behaviors, who are not inclined to ask for help when they need it, who are really challenged in terms of solving problems and coping with problems, those are individuals that are at greater risk for suicide. And I gotta say, there are lots of ways that people can develop resiliency in later life. They can develop resiliency, positive coping strategies, problem-solving skills. When I Googled this for a presentation at one time, I couldn't believe how many programs there were to help people develop these kinds of skills. And then finally, restriction to access of highly lethal means. And this means firearms for folks who have firearms in their house and are expressing or in any way indicating that they are feeling depressed or suicidal. We need to put a barrier or remove them from access to those means. When I was working in the nursing home, the lethal means that people used was their own medication. And we found several times people who had not taken their medication, but who had put it in their bed somewhere and then used that to overdose later on. So be vigilant to that kind of thing. I have reached the end of the things I wanted to talk about. Cindy's going to hit on a lot more, and I've gone well over my time here, but I want to thank you and also tell you about some of the resources that may or may not be in the resources that you already got. And I'm going to put two things into the chat box after I shut up here. One is an issue brief from the Substance Abuse and Mental Health Services Administration on late life suicide. And another is a fact sheet that I developed with my colleagues at the Mental Health Association of Maryland last summer. It's a fact sheet on late life suicide, and I'll put both of those in the chat so that you can download them and have them available. And thank you all for your time and for listening and hearing this.
Kim, if you send those to me, I can update our resource book and then send it out at the end of our conference, probably tomorrow, not literally at the end.
Okay, I'll do that. I'll do both. How about that?
Perfect.
All right, thank you.
Thank you so much, Kim. This was a wonderful presentation and actually sparked some ideas for future workshops. For example, a workshop on helping older adults to develop resiliency. So this was really helpful. I'm also going to share with Meredith the two gold standard assessments for evaluating depression in older adults. They're tools that the general population practitioners often don't use. They oftentimes will use tools that are validated with adolescents and young adults, or even some of these tools are validated with women shortly after birth. But there are two tools that are validated specifically for assessing mental well-being and risk for depression in later life. And those are the geriatric depression scale, the GDS. There's two forms, the 30 item and the 15 item, as well as the Beck depression inventory. And so I will share those with Meredith to include in the resource as well. But thank you, Kim. This was really a valuable presentation, and we do have several questions coming in. And everyone, please know that we will be taking a break shortly, but we will do a panel discussion at the end as well, where you can ask more questions of both Kim and Cindy at the end. But our first question comes from This is from Ivy Gilmore, and she asks, if a person acknowledges that they feel they have no sense of purpose or meaning to life, but deny feeling suicidal, is this a risk factor that we should be referring people for more intensive help?
This is tricky. We want to respect what people tell us, and we want to respect that people are telling us the truth. But we also need to be aware that if somebody really does want to end their life, they might be savvy enough to know that they shouldn't tell you that. So if somebody does start to talk in the way that you indicated, and then they start to walk back from that, I don't think you necessarily have to respond immediately as if they are suicidal, but I think that you absolutely don't let that go, and that you kind of put that into your hat of understanding the warning signs and revisit it with them. If they do start to walk things back and they're uncomfortable with the conversation, you might want to end the conversation. But if possible, if you can keep them engaged in the conversation, what you need to do is let them know that you're comfortable with talking about this topic. You may not be comfortable at all, but you got to fake it, because as soon as we appear to be judgmental, we're going to lose the opportunity for somebody to really tell us how horrible they're thinking. And validation can just be so important at that time. So if somebody says how they're feeling and then they walk it back and they say that they're not suicidal, a good thing to say would be, I hear you, I respect what you're telling me, but I want you to know that everything you've told me is really tough stuff. And if you are feeling distressed, I'm here to talk to you about it.
We have one more question in the chat box, and then it looks like there are 3 hands raised. And so we'll take these 4 questions and then we'll take a break. And remember, we will have the panel discussion at the end, so if you do have additional questions. But Barbara Kornbelt would like to know, what is the relationship between elder abuse and suicide?
I am going to ask Barbara Kornblit to tell us the relationship between older abuse and suicide later when we talk in the questions and answers section, because I know that Barbara is very well versed on elder abuse and its relationship to suicide. I mean, it's almost obvious that if an older adult is experiencing abuse, that is going to exacerbate any kind of mental health problem, or create any kind of mental health problem, and impact them very seriously, especially if they're unable to get away from that abuse. So Barbara, if you don't mind, at the end of today, if you could just say a little bit about elder abuse, because I know you have a phenomenal resource in your Stop Abusive Elders program that I think would be the best way for people to learn.
Okay, thank you. We'll revisit that later. Jill Vincent, you have your hand up. Do you want to take yourself off mute and ask your question, please?
No, I think that was from earlier, but thank you.
Okay. Okay, and what about Rona Gross?
Mine was also from before.
Oh, okay. All right. Do we have any other questions real quick? If not, we will take it looks like about a 10-minute break. We'll break until about 11 o'clock for a bio break, stretch our legs, get something to drink.
Just quickly, I want to remind you, if you haven't already, please take a second to do the pre-survey. I'm going to send it in the chat right now. And if you have any questions during the chat, during the break, feel free to send a chat.
All right. Okay. Thank you very much, Kim. Everyone will be back at 11 o'clock. So stretch your legs and we'll see you soon. All right. Welcome back. Someone asked in the chat box whether the screening tools were going to be available as a download, and I just wrote back to everyone that I'm going to share the downloads. These are available through the Robert Wood Johnson Foundation. So I will share the link that you can get to them specifically. The GDS is 2 forms. The long form is 30 items and the short form is about 15 items. And important to note, as Kim was saying, oftentimes in physician offices, and even older adults themselves will focus on those somatic complaints. And the nice thing about the GDS is it removes those somatic complaints. So when we think about pain, for example, and the question of, are you having difficulty sleeping? Or are you suffering from insomnia, is one of the warning signs for depression in the general population. But think about someone who's suffering from pain, right? If you have painful joints, it's going to cause difficulty sleeping. And so the nice thing about the GDS, it removes those more somatic questions and focuses more on the emotional pieces of it. Things like, are you able to find meaning in your life, is one of the central themes of the GDS. So those will be shared with Meredith, and she will send that to everybody. We are going to continue the program now with Cindy Richard, and Cindy joins us from York, Pennsylvania. So she's here in my neck of the woods where we got about 4 or 5 inches of snow overnight. So again, we're grateful that this is a virtual conference as much as we like to be in person. Traveling in the snow can be a little bit difficult. In addition to being a proud mom of 2 grown boys, Philip and Douglas, Cindy is the founder and director of Suicide Prevention of York. She holds a bachelor's in social work from Abilene Christian University and a master's in community counseling from Canyon College. Among her accomplishments, Cindy is certified online counselor, suicide intervention specialist, group, individual, and peer support crisis interventionist, a QPR gatekeeper instructor, and mental health first aid instructor. She facilitates 2 suicide survivor support groups in York County and counsels many with suicide ideation or survivors of suicide. Cindy has spoken to audiences on suicide prevention at the local, state, and national levels. Welcome, Cindy Richard.
Hi, good to have you, see everybody again. And thank you for everybody that, I'm going to stop my video because I'm like Kim, it's not necessarily that you see me, but sometimes it's nice to put a face on a person at the beginning. But anyway, I wanted to say thank you for all the presenters before, Senator Eckardt and Kim. That was great knowledge, great information. And I really do believe we can never have enough information when it comes to suicide prevention and helping people enjoy their life at no matter what age they are, but especially in our older adults that are during a pandemic or any time throughout the year when they're going through change. It's very difficult. I have an 86-year-old mother, and I'm learning a lot through her because she's still very active and she loves life. But when life, doesn't always give you what you want, it can even be very difficult for people that see life as a positive. So I guess I have to let you know what slide to turn next, but we're going to, I hope you don't hear a lot of the same thing that Kim said, but it's all going to flow together. And because this is a topic that, like I said, you can never have enough information on. But some of the objectives that I want to go through with you or work with you on today is to describe protective factors in the prevention of suicide among older adults, summarize some of those early interventions and prevention strategies pertaining to suicide in later life. And I know Kim went over some of that. But I want you all to know how to talk to someone. What are the words that you use? How do you sit with someone for hours and try to keep them from taking their life and possibly, hopefully, getting them the help that they need? And then identify some practical strategies for assessment and response to individuals exhibiting signs of suicide ideation. And at the end of the workshop, I want to talk about survivors, people who have lost someone to suicide. We cannot forget them. That is a major change in people's lives. And the more older adults that are dying, they're leaving more and more older adults behind. and children are starting to see their grandparents dying by suicide, and families are uprooted due to suicide. So we need to also address people that have lost someone to suicide as an older adult. Okay. So just so that we all are have the same understanding, this is kind of the suicidal perspective. And I really think this says a lot about what people are thinking. One of the questions I get a lot when I'm talking to people that are trying to help someone else not take their life is, what's going through their head? How do we know how they're thinking? After someone dies by suicide, what did I miss? What were they thinking? What were their last thoughts before they took their life? So, they just can't stop the pain. They're not thinking very clearly. They're always sad, and they want that sadness to go away. They don't see the possibility of change looking any better than it is today. And we're seeing that with COVID. We're seeing people that are just saying, is this ever going to change? And we have to keep people thinking that, yes, it may look different at the end, but it is going to change, and you can keep going. One of the big issues we see with all ages, but I'm seeing it more and more in our older adults, is they can't seem to be able to get control. People that like to control everything, soon as they are out of control and they can't find a way of coming back into control, they begin to lose their usefulness, their purpose. They feel out of control. They can't. Things are not the same, and that in itself is a change. And a lot of times they see things that are so out of their control that they can't fix, and they spin out of control. We see this, and we did have someone in York County take his life 4 years ago when we had a new president. It wasn't the president he wanted, and he could not live with that president in his life. And that was a change he could not control. And we are seeing some more of that now, even now that we have another new president. We are seeing some of that now. We are seeing a lot of older adults, especially, feeling extremely aggressive, angry, and not be able to control something they can no longer control. And I tend to try to bring that up to people when I'm talking with them. Do you feel you can control this situation? And if they say no, then we go on, how can you live with this situation that seems out of your control? Because we cannot control everything. Okay. Next. Some of the common risk factors that we see in our older adults. Oh, back one. And I'm just going to touch on this slightly because I know Kim touched on it too, was that depression. Depression feeds suicide. It is the foundation of most suicides, is depression. So once we can see what's feeding that foundation, feeding that depression, we are able to move forward, hopefully, and be able to work with this person and try to bring them out of their current state. The death of a loved one, a physical illness, or a perceived poor health or physical illness. How many times do we have people that just say, I know I have this, this, and this because that's what it says on the internet? People are Googling their symptoms more often because they can't go right into a doctor, or they have to do telehealth, or they have to do things. So they just say, well, I'm just going to look and see what it says on the internet. Well, perceived poor health is one of the big risk factors. social isolation and loneliness, and we're seeing that with COVID, especially right now. And I work with several senior residential sites here in York County, and they are just wanting some kind of social, having the ability to socialize. Some of the case managers and people that work in the senior residential sites here are just pulling their hair out on how can we make this better for them, because nobody is allowed in. The death rate is high, whether it's suicide or for any other reason in our senior sites now. Major changes in social roles. Again, sometimes we see when a husband will die and they are known as this guy's wife, and they have a certain status in the community. And when that person dies, they find that they don't necessarily have that same social role or that same status. And I saw my mother go through this, and she found out that she was just the wife of. And she found out that some people didn't even know her in a group without him standing beside her. And that just absolutely blew her away, because she never felt that when he was alive. And so I think that's something that we really need to take into consideration when we're looking at changes in our older adults, is what is their social role, and has that changed? Next. So how can we help? So what has changed to an older adult? Again, Kim went over some of this, and so I'm going to go through this. And again, if you have any questions on this, feel free. Loss of independence, we all know that. But loss or career loss or change. Some people work, and I look at, I kind of had to grin at this, because I look at Senator Eckardt, she's obviously worked into a very prime age, and she's as she's as excited about her job as she was probably years ago. But some people are not, especially with the COVID again. Some people have had to leave their jobs due to maybe poor health or just retirement in general. When people retire, that is a whole nother ballgame. And if you don't have something in place to replace that career that many times has defined who you are, it's a huge change. I've had people come to me and talk to me about, why do I feel the way I am? Why do I feel like I no longer have a purpose? Why is it that I feel like I had all these ideas for retirement? So why am I feeling this way? And I think we have to mourn the career that we had. We have to grieve the loss of going into work every day. We see it with COVID too, people having to work at home. I did the opposite after retirement, and after being out of the office for 3 years, I took a very, very limited role in helping Lancaster County with their suicide prevention just a few weeks ago. And my first day in the office was huge. I was exhausted. And I told myself that, yes, you no longer have, you have to grieve the loss of going into the office, you have to grieve, but you also have to be prepared to change it around. So the whole thing is change. How can you retrain your brain for change? And that sometimes takes a lot of work, especially when your job defines you. And I know people in the helping fields, we're seeing a lot of that their job defines us. Loss of social contacts. Loss of change in physical appearance. We change as we get older. And sometimes we have to take that into consideration when we're viewing change. The change in weather. We know that there is a high level of depression in people when we continually have gloomy days. Look at yourself through COVID and everything else. When the sun is shining, we want to get out. But we also have to look at a lot of people that, especially older adults, that have had and continue to have, or just find out that they have social anxiety. And it's very difficult for them to go out and be among groups. So when they have to go out and be among a group of people, or even just to go to the grocery store, that is a change for them. And having to now wear a mask and all the other stuff, it doesn't take much for one person to tick them off, but it also doesn't take more than one person that just smiles at them in the grocery store and or tells them to have a nice day or hello to change that behavior too. Next. So you may want to think about what could have been done to prevent the change. Well, maybe I retired too soon. Maybe I just thought I wanted to leave my jobs. Maybe, I didn't do enough before they died to feel like I was part of their life. Having someone come back into your life is a change. Well, maybe not. And I know older adults, there are a lot of older adults that begin to date after the fact. And well, maybe I shouldn't be doing that because it's just not what I was supposed to be doing after my 50 years of marriage and that type of thing. You may become preoccupied about ways that things could have been better, imagining all the things that will never be. We can all sit around and think about how we wish we could have done things differently in our life. Again, did we have control of any of that? Are we in control with things that maybe we wish could have been different? And sometimes imagining that things could be different, and they can be different, can be good. But if you're sitting around imagining all things that will never be, that's not up to you. It's not your, it's not anything that you're going to ever be able to do. Or why did this happen to me? Kind of the home thing. It can bring you down, and it can get you on that couch all day, or it can get you in bed all day. And the words that we use, I think sometimes can change that in people. A telephone call, just telling somebody that they matter and that you are thinking about them, can change their day of sitting around and being very preoccupied with the things that will never be. This can provide insight into the impact of the change, but may hinder the healing process. We cannot continually bargain with ourselves. We cannot, I've heard a lot of people say, I've tried to bargain with God. I've tried to bargain with the weatherman. I've tried to convince people that they're wrong and they're not, and they don't think they are. And so you have this constant turmoil of the whole bargaining aspect. We can provide insight into the impact of change on people. We can talk to them about change. We can talk to them about having what they can do possibly to change their life. If they want to do it, they're going to do it. I don't think there's anything that makes me more angry than somebody that sits around and just complains all the time but doesn't change or doesn't attempt to do anything about it. And you see that when they attempt to do something about it, they're much happier, and they're I don't know if you all have heard Kevin speak from the man that jumped off the Golden Gate Bridge. He was bargaining with himself before he jumped that if someone would have just said hello to me, I would not have jumped. Someone came up and wanted him to take their picture, but that's not what he was bargaining. That's not what he was saying to himself. That was not, he would never have jumped if somebody would have come up to him and said hello. And he still talks about that. So we can't always bargain and make it come out good. Go ahead. Factors that may hinder the healing process. We cannot avoid or minimize someone's emotions. We may think, why are they getting so upset over that? It's so piddly. We can't do that. We can't take somebody's emotions and treat them as if they're not important. I've had people say to me, well, they lost their husband, but I lost a child to suicide. So why are they so upset? It's worse to lose a child. No, yeah, it is. It's awful to lose a child, but are the other person's emotions less important than your emotions? And the avoidance and the minimization of someone's emotions can make someone very angry because they just don't get it, is what it comes across. The use of alcohol or drugs to self-medicate. There's been a lot of studies done on alcohol and drugs in suicide, and they're finding that alcohol is more dangerous when it comes to someone taking their life than drugs. They're both awful, and a lot of times we'll see both in a person's system. But alcohol gives you the ability, they're saying, more than drugs. And people that die by suicide, about 94% of the people that die by suicide have high levels of alcohol in their system. They self-medicate thinking it's going to be better. And as you all probably know, that if you have high levels of alcohol in your system, you tend to do and say things that you probably wouldn't do if you didn't. And so self-medication isn't working. And a lot of times we'll see this in older adults because they will hold on to their medications because they don't think they need them at the time, and they take more than enough when they feel they need them. And people that take anti-anxiety drugs and different types of mental health drugs sometimes will go that direction. Avoiding feelings through over busying oneself. We want people to stay busy. We want people to feel like they are needed, outside of the home. But sometimes I see this, and I see this with people that have addictions too. They want to really, really stay busy so they don't have to focus on their addiction, or they don't have to focus on their sadness or the change or the loss that they're going through. And sometimes we need quiet time. I always tell, especially single moms, that they need their me time. They need that time where they can just go and be by themselves or do what they want to do at least once a week. And I think we all need that. And older adults are no different. They need that me time. You cannot be busy all the time, because my first question is, what are you trying to hide and what are you trying to avoid if you're busy all the time? And it's just not healthy. We need to have some downtime, and I know COVID is causing some people to not be able to experience some of their downtime that they normally have. They can't go on vacations. They can't experience life like they had planned on, especially in retirement. And they can't see their grandkids. They can't see their family, and that causes more anxiety. So we have to find other ways of giving ourselves some healthy downtime, not to sit around and think about things that we can't do, but things that will keep us healthier. And this is where some of our gyms are causing some problems. There's a lot of gyms that are closed right now, and that was people's way of having their downtime for so many people, and which was, and many times is a healthy outlet, and it's their quiet time. So we are seeing, a lot of barriers when it comes to this, and so people are trying just to stay busy a lot more than before. Go ahead. So I want to get into some key interventions. There you go. Most important out of, I don't care what you do and how you ask a question or whatever, the most important thing that you can do for a person that is contemplating suicide or is experiencing deep depression. Just because they're experiencing deep depression does not mean they're contemplating suicide, but it's something you have to keep in the back of your mind. So is to listen. Listen, 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 because that's what they want you to do. And we tend to want to give all kinds of suggestions and whatever, so we don't listen. But listening is the most important thing, because that's what they're wanting. They're wanting someone to hear them. They're wanting someone to see them and to listen to them. Listen to the words they choose and listen to what they're not saying. Read between the lines so that you can have a meaningful discussion with them. Be aware of those warning signs. If you are getting ready to go in to talk to someone about suicide ideation or their depression, have those warning signs in the back of your mind. Have your options laid out ahead of time so that when you go in and listen, you can listen with those signs in the back of your head and you can read between the lines. Then asking the question. This is an area that we could do a whole workshop on. And if you haven't gone through a QPR workshop, I highly, highly suggest that you do that, because that's what they focus on. How do you ask the question? You question it, you persuade them to get help, and you refer them to get help. So asking the question is the first step, and that comes with listening. Listening to what they're trying to say to you so that you can ask the appropriate questions. When I get this gut feeling that someone is really feeling suicidal, or they have a history of suicides in their family, or they have attempted suicide themselves, or they've had a long history. And this is one area that I think needs to be thought about a lot, is that sometimes we don't see older adults until later in life. We don't know their long history. And they may have had mental health issues back in high school. They may have had long-term mental health history of mental health issues. So we're just meeting them now. So it's important that you know their mental health history, because many times they have had their good times during the middle parts of their life and they haven't really been affected by their mental health. but then due to hormones or due to other things that have happened in their life, they are resurfacing again the same type mental health issues that they had earlier in life. So it's really, really important that we get to know the person so that we know what questions to ask. So I always begin, if I get this feeling of suicide ideation in a person, I always ask them how, because we want to know if they have a plan. Because if they have a plan, they need to get help immediately. And they may not only have one plan, so you have to find out whether they have more than one plan. So how would they take their life if they could? How would they go about taking their life? And where would they take their life? What area would they take their life? I'm working with a family right now with their son that he has talked about taking his life, and he's talked about jumping off a bridge in Philadelphia because they have the tallest bridges. And his parents just found out the other day that he has a ticket to Philadelphia on the 18th. They knew where he was planning on taking his life. So now we need to ask the question, when? They now know when he's planning on taking his life. So we have the how, the where, and the when. And if you can get that, then, and sometimes the how is, I'm going to jump off a bridge, I'm going to use a gun, I'm going to take all the pills I've kept in my closet for years. They have been thinking about it, so they have answers to those questions. So the how, the where, and the when gives you an idea whether or not they have a plan. If they cannot answer those questions, you cannot just put it aside either. I always then ask them, then what is feeding your thoughts of suicide? What is it that keeps telling you that you want to take your life? Because you obviously have not gotten down to the foundation of what is actually feeding that suicide ideation. And older adults, like Kim had said earlier, is a lot of times they don't know how to express themselves. They don't know how to tell you what they're feeling. So you have to go into helping them to describe. Maybe you might give them some feelings in advance and say, do you feel this? Do you feel this? Ask them those questions. A lot of times it's anxiety, it's change. They don't, as we know, no one wants to take their life. It's the fact that they can't control all those other things that are going on in their life. And they're mourning, or they're in deep sadness, and they don't know how to get out of it. And they don't know that people can help them get out of it. So ask those questions. And while you're asking those questions, find out who all is involved with them right now. Who else are they talking to? Because you need to get a picture of what is actually going on in this person's life. You need to get a picture in your mind of who all is involved. Who else are they talking to? Are they talking to a minister? Are they talking to a therapist? Are they talking to a grief counselor? Are they talking to a case manager? Who are they talking to about this? And you need to involve, and how close they are to their family. Where is their family? Maybe their family all lives out of town and they haven't been able to contact them. Or maybe they're really, really close to one of their grandkids. Or, find out what makes up their family and where they stand in it. Find out the history. History is so important when you're trying to work with someone. So reach out, involve everybody in their life. Now, there may be some people that they don't want you to involve them in. So you need to find out who those people are too. Don't talk to my kids about it. I don't want to get them upset. Don't. You have to acknowledge that unless it becomes an emergency situation. And then if it becomes a 911 situation or some emergency situation where they're actively thinking about suicide, you do need to contact the family. But provide support. Know what's in your pocket, basically. Know the support that's out there. But do not just give them a bunch of pamphlets, because as we talked about earlier, older adults especially have a very, very difficult time maneuvering the system. It's hard for people in the field to maneuver the system. So we can't expect them to just have a pamphlet and say, go find some resources. Here's some resources, call them. That's work for them. And you have to take their depression into consideration. Instead, while you're sitting with them, say, how about if we make this call together? How about I help you make this call? How about I go with you to, help with this? I was taking someone the other day to go get their first COVID vaccine. And they don't allow anybody in there that is not getting a COVID vaccine with them. And this person was quite fragile. So I had to leave. But before I left, I asked him, will you be okay? And he grinned and he said, yes, I will be. And the nurse said, we'll take care of him. That made me feel so much better than if I would have just opened the door and sent him in by himself. And while I was waiting in the car, I saw a lady that I swear she was close to 100. And her son, which I'm assuming it was her son, was probably in his 70s. And a few minutes later, and she could barely walk, a few minutes later, I saw him leave. He was so distressed that he had to leave his mother in there by herself. And I felt so bad. And I thought, we should have something set up for this, where we are helping our older adults do something as simple as get a COVID vaccination. And you don't know what kind of situation you're leaving them in either. And I saw the distress on his face and I understood and I felt so bad for him. And because I felt bad myself, even as a caregiver, to leave somebody there that I knew very well was probably going to do okay. I can't imagine the other way around. So provide them with support. Let them know ahead of time what's going to happen. If you have to take them to the therapist or they go to a therapist, give them a background on what's going to happen. Make sure they are especially if they have some dementia, make sure they are very, very educated, and you continually educate them as you take them to where they need to go. Create hope. Let them know that this is for them, that they are going to feel better for doing this for themselves. And just create that sense of hope that they are important. They are important to you and they are important to this world. Because I think sometimes our older adults feel so forgotten that they are not important to the world in general. And I feel bad about that, because we have not created a sense of hope for our older adults like we should have. And the whole discussion of press that button and another button, forget it. I'm not, that is just ridiculous. I hear more complaints over that than anything. So here are some tips for asking that suicide question, because that is the most important step when you're sitting down and talking with someone. If in doubt, don't wait, ask the question. Don't wait. If they are talking suicide, you cannot ignore it as if, oh, that will never happen to them. They're just upset about something. If they use that word suicide, you cannot ignore them. And I know it's hard. It's the hardest thing you will ever do, asking someone if they want to take their life. So you may want to practice it ahead of time. If the person is reluctant, be persistent. They will be reluctant. They don't want you to know. Our older adults are very proud of themselves, which they should be, and they don't want to show any weaknesses. And they see this as a weakness. And we have to let them know that it's not a weakness. And if you know someone yourself, or maybe you yourself have gone through this too, and you can identify with that person, that's fine. If you cannot identify, don't pretend to, but be persistent and don't lie to them. Just let them know again that you're offering hope and you care. So talk to the person alone in a private setting. Allow that person to have that private place. Allow the person to talk freely. Don't continue to interrupt. They want you to listen, and you have to listen. Give yourself plenty of time. Don't be looking at your watch. Don't have anything else planned, because it could take a long time for this. So make sure you have cleared your schedule. And again, have those resources. And I'm so glad they're going to be giving out a lot of resources today. But how you ask that question is less important than you asking it. So if you fumble it, that's okay. Just the fact that you've asked it is important. Next. I didn't want to end this discussion today without talking about survivors. A survivor is someone who has lost someone to suicide, and I think they are a forgotten bunch. And we are so prone to think about trying to keep people from taking their life. We forget about people that have lost someone to suicide. And our older adults are a lot of times the people that are left behind as survivors. And we need to understand what they're going through. So someone that is left behind due to suicide, they have a grief process to go through. And sometimes it's harder because, again, they don't want to feel weak. There's a lot of stigma that is attached to survivors. And there's a lot of feeling of failure that survivors attach to themselves for not catching it in time, not allowing someone to live longer, and not, they're just all this guilt. But sometimes even our older adults can be the best advocates for other survivors, and for suicide prevention in general. And we cannot forget, and this has been brought to my attention twice in two survivor groups that I run. But one that really shook me just a few weeks ago was that we had a lady who had been married to her husband for 58 years. And she had her grandkids and her kids encouraged her to come to a support group. And she came to our support group. And towards the end of the group, she just started crying. And I thought she was crying because she hadn't said much in the group, which we don't require. But she was hurting. She was feeling grief. And so I acknowledged her, and she said, "I'm crying because I don't feel grief." She says, "I am crying because I was abused for the whole 58 years I was married. And I thought I had kept it from my kids, and only to find out I didn't." She says, "I'm crying because I feel so much relief that I can now live at the ripe old age of," I think she was like 80 years old. And she said, "I feel so guilty because I can't feel like everybody else in the group." We all had tears because she was so very right that sometimes the grief process is confused and mixed up with relief. And we see that in our older adults. I had another lady tell me that one time that her husband, she wasn't angry at her husband for taking his life, and that's not what she was grieving. She was grieving and angry over what changed his life, and that was the stroke. So this is part of this picture that we have to build. And the lady that was abused, she sat and told us that the night he died, we all family stood in the kitchen, and she said, I hate to say this, but we almost celebrated it. And luckily, the group was very kind to her and was very open to her, and because it could have gone very easily the other direction. So I think we have to look at the whole picture, and again, that goes to listening. And getting the picture and the history of a person and we just can't assume that a survivor is grieving the way other survivors are grieving. And they have to do it at their own pace, and they have to do it on their own time. Okay. So we talked about this a little bit with Kim on how to promote well-being. And I'm seeing this as a really, really tough thing to do right now with older adults. I know I'm going through a lot of these stressors myself because I can't travel and do things like that. So some of this stuff is good when we aren't in a pandemic. And some of this stuff we have to, think outside of the box on and try to bring it to our older adults. And those are activities and programs. They're basically not going on right now. So what can we do in a pandemic? Build relationships, maintain that sense of purpose. If you can't do anything for an older adult, try to maintain that sense of purpose, because that is what they are lacking. And right now they are really lacking that. Give them a way to be physically active. Give them a way to have a purpose in their day-to-day life. If they have good family relationships, try to build those family relationships, allow them to come together. The sob stories right now are people that were dying of COVID and had to die alone, and people that are in homes that are having to die alone. It's just overly sad. And so we need to maintain that care that comes from family relationships. As much as you can, involve social and recreational activities. I know I have a few older adult friends that I Zoom with every once in a while, like once a month, that I just having that face to face, and we have a glass of wine or something, too. There's one of them that we were always used to getting together for a glass of wine. And so we do our wine Zooms now, once a month, and catch up on what's going on. That gives you that sense of involvement. It gives you a little bit of social. I don't know how recreational it is, but it does give you a little bit of social. Try to keep life as normal as possible. And normal, like Kim said, means a whole lot to a whole lot of people. So know what normal is to a person. That, again, you're going to get by listening to a person when they're talking to you. You're going to get a sense of what makes them thrive, what makes them happy, what puts them in that good place, And I know a few weeks ago I had to get out of the house. I had to go for a drive. So I went to Eckardt City. I've always wanted to go to Eckardt City and go through the historical area there. I just parked my car and walked. Well, I happened to park it in front of this. And if you ever get to Eckardt City or know this place, I love it. It's a place where they sell a lot of dipping oils and stuff. It's right on the main road there. And my car just parked in front of it. But I am used to every year taking a trip out to Colorado and doing that. And at one of my favorite places in Colorado. And when I walked in, the lady asked me, because I'd been in there for a while, she asked me if she could help me. And I said, no, just let me be in my happy place right now. So I told her why. And she laughed. She said, we get a lot of people that come in like that. And it made me think, why can't we do things like that? Why can't we do things safely and be in that happy place for just that moment? And then I drove home feeling quite good about the day and feeling like I had done something. So that is normal for me. That is recreational. We need to find what works for people that we are talking to and listening to. Some things that you could do to take care of yourself, and we can all do this, is try to, again, get rid of those negative thoughts. We cannot focus on negative thoughts. And we all know people that do that, and we need to try to help them through it. Reduce stress and improve mood. Know what nourishes you. And if you don't know what nourishes someone else, ask them that. What is your happy place? What makes you happy? What are you missing today that you had before COVID? And try to see if you can put that into place somehow for them. Remember your best attributes. And sometimes people have to be reminded again of why important they are. I have people that have been feeling so negative about everything, and all I have to do is say, you're really good at this. And the smile automatically comes. We can turn people around by letting them know how important they still are and what they give to you and everybody else. Help them practice gratefulness. Before they go to bed at night, I recognize, I acknowledge, and I appreciate, and put something after each one of those that's positive. And eventually we retrain our brain to be more grateful than ungrateful. And we tend to think of more of the happy times and the good things in people's lives than we do the negative. So remember, each person deals with change in his or her own way and in his or her time. We cannot put time on this. And please do not ever, ever say to a person, you've been grieving for a year, aren't you over it yet? When they have had a suicide in their life, or when they have been dealing with someone that is suicidal, they can grieve as long as they want. If it's been a gigantic change in their life, their life is now before and after, and because it's the dividing piece in their life. You will let go and accept your change in life when you have worked through all the pain and possible grief. They can put it on a shelf for a while. Triggers are going to come up, but they'll have the tools then to handle them when they come down off the shelf. So give yourself time, but don't expect time alone to heal. Just take one day at a time. And if you have lost someone to suicide, you know that it's okay to be selfish. And it's okay to say, I cannot do this today. You may set up things at parties or go see people, and all of a sudden when you wake up that morning, you just say, I can't do it. That first year is a lot of that. And the second year is even more of a change, because you're having to change maybe sometimes friends. You have all new friends, you have an all new life, and sometimes your life looks totally different in the second year. So give yourself time. Don't be critical of yourself, and don't put expectations on yourself so that if you don't meet those expectations, you see it yourself as a failure. Go ahead. So you will be whole again. You just have to take it one step at a time, and know that those triggers, and any trigger you have or any death you have after, or any change you have after the fact, is going to trigger the change or the death that you're already mourning. So please be aware of that. And but just know that you have the tools in your toolbox now to work through that. Like we've said from the very beginning, and I believe Diane said this at the very beginning, depression is not a normal part of aging. It is treatable. And unfortunately, we don't treat it early enough, and it can seep into older adults, or in older adults, we need to help them, and they may never realize that there was help out there. So please help the people that are feeling down right now. And let them know they matter in this world. So I gave the suicide prevention lifeline number, and that is very helpful. I have heard that they have been overused lately a lot, and that sometimes you're put on hold. I hope that, and I know they were given more money to expand, so I'm hoping that's not the case anymore, but open it up to questions and discussion. Thank you.
Thank you, Cindy, so much. If you want to show your video again, that would be good. That was a really informative presentation from both you and Kim, and just reading through the comments, the attendees are very grateful. Elizabeth wrote, and there are a couple of questions, but I'm going to start with this statement. Elizabeth wrote that the advice that you just shared is very good for anyone contemplating their own death by suicide. And it just reminded me of something that I read several years ago, looking at some research on the assisted suicide laws. And there were some data that came out of, I believe it was Washington State, looking at individuals who had opted for, I believe they had opted for death by suicide, and loneliness. So a lot of people think it's pain when people are at the end of their life, and especially if they have a terminal condition, that it's pain that's helping them to opt toward that assisted suicide. And what the research data showed was that it was the loneliness and the isolation that they were feeling as part of it. And I think that was a big part of what both you and Kim shared this morning, that idea of helping people to connect with others, that feeling of meaningfulness with older adults, perhaps connecting with their grandchildren and their family members, continuing even in whatever illness they may be experiencing, to continue to find joy and meaningfulness and a sense of purpose. So I echo what Elizabeth wrote. Also, a couple of people are noting, Monica, thanks for the storytelling. I think it's always helpful. Both you and Kim had shared some personal examples from your own work experiences, so that was very nice. Thank you. Christopher wrote, very early on, you had put out the figure that about 94% of people who complete suicide have high levels of alcohol in their system. He'd like to be able to cite that. So do you have a resource or a source for that? And if you can send it to Meredith, then she can send it out to the group as well.
I will do that. Yes. It's also a part of the QPR presentation too. So I will send that out.
All right. Let's see. Just trying to go through here real quick to see what questions I see before we pull out. A lot of people are just very grateful for the information, very helpful. Allison wrote, thank you, Cindy, great information. She's echoing what a lot of people, Lisa Boxwell, same thing. Oh, here's one. Are there any tips we should avoid to ask while helping someone?
I think one of the biggest things that you can do to avoid, when you help someone, is don't make them feel worse than they already are. I know some people say, well, yes, you do. You look really horrible today. And that's not a good way to, you don't want them to feel like they feel worse than they did when they walked in to talk to you or whatever. Try to be upbeat, try to be positive, try to understand what they're going through. When someone's going through this, they do not want you to lie to them, because that's what they feel like everybody has been doing to them up to this point. So be honest with them. And if you can't say something positive, don't say it, especially if they are suicidal. I never tell someone that their feelings are ridiculous. I never tell someone that, I never say to anyone, how can you feel this way when you have all this good around you, or you are quite financially sound, or, anything like that. Whether we really understand how they feel, that's not important. we have to understand that's how they feel. And we have to go from there. So try to put yourself in their shoes if possible. And maybe some of you have been in their shoes. So that's maybe a little easier to feel. But try to let them know. And if you could, even if you say to them, you know, you must really, or I can't imagine feeling this way. This must really hurt. That's also identifying their feelings, that you can see what they're feeling, but it's not putting them down. So a lot of it is just, you know, being honest with them, but also saying to them, without saying I understand, because that seems to be a really easy word for a lot of people to say, you're hurting. And I can see that in you, because that's where you get from listening and all of that too. So try just to be as positive and to connect with them on a more positive, where you're actually seeing them. I think so many people feel like they are not seen these days. And you can practice doing this just by walking through a grocery store, by just saying hello to an older adult. You can smile through a mask. Your eyes smile. So even you can say hello, you know. So practice that, and because you never know when one hello is going to change somebody's life that day.
Can I jump in? This is Kim.
Yeah, Kim, why don't you go ahead? Let's go open it up for the panel. We've got about 15 or 20 minutes left. So let's, Kim, if you can take yourself off of, or put yourself on video, and let's take down the slide and open it up. And if people want to raise their hands, and then we'll be able to unmute you and you can ask questions as well.
So it just says that I can't start my video because the host has stopped it. So I can't make it do its thing. But I wanted to tag on to what Cindy said and add that so much of the way we communicate is nonverbal. And so it's really important to look the person in the eye. Don't look away. Oh, here I can start my video now. Just be careful that you're not making any kind of face, like you can see my face now. So, you know, if you're squinching your head or you're shaking your head, that's going to be very unhelpful, because what you're doing is projecting that, you know, that you don't want to talk about this, or that you're offended by this. And you also don't want to make it about you by starting to say, oh, I've felt like this before, and here's what I did, or here's what I think. It's not time for you to talk. It's time for you to listen, as Cindy has said so well. So, and the other thing, not to change the subject.
I'm sorry, go ahead, Kim, I'm sorry.
I think about that picture that I showed with the older gentleman who's crying, and there's, you know, inside of us, we want people to feel better. So we want their mood to change. And so we are oftentimes trying to figure out, how can I make this person happy? And that's to the detriment of what that person needs right now. So it's not our responsibility to make them happy. It's our responsibility to really listen and reflect that we are hearing how they feel. We may not understand it, but we hear them.
Your nonverbal information, it is so true. I can remember going back in my early social work days, taking a class and just nonverbal stuff. And it's amazing what you do when you're talking to somebody, when you're uncomfortable talking to somebody, even crossing your legs or putting your hands like this and your arms like this, where you're almost putting a barrier between the person and you. Be very mindful of that. If you cross your legs one way, if you want to cross your legs, have it the open side towards the person, not the closed side. So it's just small things like that, but face says a whole lot, you know. Just like we know when somebody walks into our office or whatever, we can tell almost how someone's feeling by looking at their face, you know. So at least sometimes I can, and so we have to kind of put that aside and try not to show that in our own face, you know, too. but there is a caring face that is always nice to show.
I'm thinking about conversations that I've had in the past during training sessions when I'm reviewing the geriatric depression scale, for example, and a lot of people are hesitant to ask those questions because they don't want to bring up feelings. So what advice do you have? Because we have to, and you're saying, we need to be asking these questions. We need to have people be opening up to us. But even when the service providers are hesitant to ask those questions, what advice do you have to get someone to be more comfortable, help someone to become more comfortable in having these conversations?
First of all, we need to be offered more training when we're going through school and asking these questions, to have some just specific suicidology courses. But it is uncomfortable, and because you don't want the answer to be yes. And you have to decide what's more important, your uncomfortableness or the person's health and the person's life. And I was very uncomfortable, and I still am after all these years. I'm still very uncomfortable asking someone that question. But you have, again, like Kim said, it's not about us. We've got to put it aside and talk to them about what they are feeling, and showing them that we are listening to them. And that can really change a person around, because they want you to ask that question. They have been wanting someone to see them, to listen to them, to understand them. And so when you ask that question, you are saying that to them. You are saying, I see you. I'm trying to understand what you're going through, and I'm listening to what you need. You are important. And many times that's what opens up the floodgate, of all these emotions that are going on, and it builds that relationship between you and the person that you're talking to. And so that, that is something you have to practice. If you want to talk to people that have all levels, any level of suicide, and in them, you need to practice it. And you need to practice it with someone or in front of a mirror or whatever works for you. But you need to practice. And like I said, it's not how you ask the question. It's just that you ask that question.
In mental health first aid training and in QPR training, they emphasize the importance of practicing, as Cindy just said, because it's one of those things that's on the tip of your tongue and you don't quite know how to get it out. And if you practice saying it different ways, you might find the one that you're most comfortable with. So some people might flat out say, it sounds like you're killing yourself. Is that what you're thinking about? Other people may not be comfortable and say, have you thought about suicide? So there's different ways that people need to say it, and they need to practice in order to be comfortable. And if it doesn't come out of their mouth, then we're missing a life-saving opportunity.
Yeah. Like,
and Elizabeth,
something as simple as, do you want to die? And so, that's so true.
Elizabeth writes, and a lot of people noted, the importance of you sharing your experiences. And Elizabeth wrote that sometimes sharing personal experiences can let people know that you do understand the black hole that they are in. Giving hope and understanding is huge in helping someone to realize that there is a way out of that black hole, at least for the day. The short-term goal is to help that person to avoid death by suicide for that day, that week, that month, that year. But the long-term goal is hopefully getting that person into therapy for how long it may take for that individual to develop and practice self-saving skills. And I think you both would agree with a statement like that.
Mm-hmm.
On a certain level, again, it can't be about you. And if you have not healed or you have not begun to heal, you should not be talking to people about suicide. If you've lost someone to suicide, or you are thinking about suicide yourself still, you have to be healthy too. And I think we see that in support groups. We see people that they've just lost someone to suicide and they want to facilitate a support group, but the support group then becomes all about them and not about the people sitting around the table. So there is a fine line there that, yes, so I have also seen people feel very comfortable when you can identify with them. But you have to, there's that fine line of where they know that you can identify with them and you are no longer the topic. They are the importance of this topic. They are the ones that they're the ones that you're trying to help. And so I think, and that builds that relationship, and building that relationship, talking to someone about suicide is extremely important. So I agree, but there's a fine line there about on which way to go. And you have to be healthy yourself in order to be talking, or, I don't want to say counseling with someone with suicide ideation or whatever, but you have to be educated and know the time where it's important to bring that up.
I want to say another thing. Even after I was trained, when it happened to me, that I was talking to somebody who, when I realized that they were suicidal, like every hair on my body stood up and my emotions made the front part of my brain forget what it is I was supposed to say. And it's okay to tell that person that that's your experience. So it's okay if you say, I'm coming to understand that you don't want to be alive. And I'm hearing what you say, and I want you to know that I'm just confused about the right way to tell you that I really believe that you can feel better. And now is the time when you're feeling your lowest. And I'm wondering if together we could call a hotline, and do that with them.
All right, well, we do have probably about 5 or 10 minutes left, and I want to invite Barbara Kornblit. And she had asked the question earlier about elder abuse and suicide, and Kim said, let's have her actually talk about it. So Barbara, if you could take yourself off mute and also show your video, please.
Okay, I'm trying to, can you hear me?
We can hear you.
I'm trying to get my video, let's see.
I can fix your video.
Okay, that would be great.
It'll ask you if it's okay.
Okay.
Hey,
Okay, there I am. Okay, hi, thank you very much for allowing me to speak. My name is Barbara Kornblit. I work for Safe Stop Abuse of Elders, which is part of Chana, and Chana is the Jewish response to domestic violence and elder abuse and sexual abuse in the Jewish community and also beyond. And I asked the question because elder abuse happens to 1 out of 10, at least, elders in our communities. And some of the very signs and symptoms of suicidality are also the signs and symptoms for abuse. There is a correlation in some of the literature that people who have been abused are more likely to attempt suicide. And I think it's very important for people to be aware and to know how to ask those questions about abuse, as well as the questions about suicide. We do see that older adults are more vulnerable to both abuse and suicide if they're isolated. And certainly we have a lot of isolation right now, more so than ever before. So I'd encourage people, if they have questions or if they might know someone who is being abused or want to learn more, to contact SAFE. And I guess can I put a phone number in the chat?
Yeah, please do.
Okay, thank you.
And I'll also, if it's okay with you, Barbara, I will add it to our resource page that everyone will get as well.
Great, thank you.
Talking to somebody about abuse, about suicide, about mental health, about substance use, there is a lot of research that's been done about the discomfort that even health and human service professionals have with asking those kinds of questions. And I would challenge all of us to wonder if we would say the same about younger people that we might talk to, because this is an ageist thing, you know, thinking, oh, this is a sweet little old lady. She wouldn't be abusing her pain medication. Or he's so happy all the time. He wouldn't be feeling suicidal.
Emily wrote, and I think this is probably a question for you, Barbara, but I'm not sure. How can patients seek or get help when they don't feel comfortable around their caretakers, their family members who may not allow them access? It was reported to APS as the patient is still scared.
If people don't feel comfortable around their caretakers, we would urge anyone who knows someone in that situation to call us. We do a lot of consultation with family members, with folks who are concerned about an elder who maybe can't talk to us yet or doesn't have that time alone to make a safe call. But we may be able to strategize with that family member on how to make that person more safe, or how we could communicate with them possibly when they're at a doctor's appointment, or they have just like tiny margin of time when they could communicate with us.
And if you don't stop asking the questions just because they say no once, I'm thinking, as Barbara's speaking about, readiness, and that's true for all that we've been talking about today.
Mm-hmm. Thank you.
Burton, thank you. All right. Looking, does anyone have any other questions before we wrap up? Any final comments from our panelists? All right. Well, thank you, Kim and Cindy, and now Barbara. This was a really important conversation. I'm looking forward to the evaluations where you not just talk about the content of this conference, but also give us suggestions for follow-up conferences, right? The idea of a training program, a workshop on resiliency, I think would be really important for people in this group. So if you have other ideas for conferences related to this topic or other topics, please share that with us so that we can continue to build content which is going to benefit you in both your professional and personal lives. I do want to just give you a heads up on some additional conferences that GGEAR is sponsoring over the next several months. On April 14th, we're working with the Eastern Shore Area Health Education Center. We'll be hosting a conference, a 3-hour conference beginning at 12:30 that afternoon on the convergence of COVID-19 and social justice, health inequity, and later life. And that conference will include an update from Dr. Wilbur Chen, who is a virologist at the University School of Medicine and also a member of Governor Hogan's COVID-19 task force. So that is the third of our series of presentations providing updates to the community on COVID-19. And this one will focus specifically on older adults, minority groups, persons of color, et cetera. But then we're going to tie that in with a broader discussion on health inequality in later life and begin a discussion on how do we begin addressing those challenges. On May 14th, the Area Health Education Center in Western Maryland, AHEC West, is going to be hosting a conference titled Motivational Interviewing with Older Adults. If some of you may remember that we had motivational interviewing as a topic last May, about a year ago, and Mary Hodorowitz, who is a professor at the University of Maryland School of Medicine, School of Social Work, will be facilitating that 3-hour workshop. This is part 2. More hands-on than what she gave last year, but even if you didn't attend last year, there will be some background information. So it really is open for everybody, regardless of whether you participated last year or not. Students, I know we also have a number of students who are currently on this webinar. I want to remind you, if you are a University of Maryland system, so Salisbury University, Towson University, and any of the University of Maryland system schools, we do have 5 opportunities for interprofessional trainings for you this semester. These are our GATE programs, Geriatric Assessment Interdisciplinary Training Programs. in which topics that are covered in this presentation are going to be implemented as part of those trainings. You're going to consider these through case examples, interviews with older adults and family members. You're going to be working alongside professionals representing a variety of disciplines to help you understand the importance of these interprofessional teams, that it can't just be a medical doctor who's approaching it from the medical perspective, but we need that social worker, we need that audiologist, we need the pharmacist and the dietary to truly get a better assessment of the individual and develop a comprehensive treatment plan for those individuals. So students, if you are with the University System of Maryland, there should be lots of flyers around your campuses or with your professors. So please look for those, and we'll be sending them out again in the next week or so as well. And let me just quickly go through the chat box here. Lots of thank yous. Oh, Barbara's contact information. Barbara, hopefully you're still on. Could you put your contact information into the chat box so that people can write that down, please? And she did. Okay, so there's her email address. The post survey link, Meredith is asking that people please complete that.
There was a problem and I just fixed it in the survey, so you can go back in and redo it. Sorry, I thought I updated something and I didn't, but it's fixed, and so you should be able to have no problem moving forward with it.
Sandy Mowbray is asking about the motivational interviewing presentation. I believe we have a couple of people from Western Maryland attending this webinar. Joy, are you here, or Susan?
I'm here, Diane.
Yeah, can you, the date for that, is that true? It's May 14th and it's a morning presentation, correct?
That's correct. And Sandy, I will make sure we get the flyer out to you.
Okay, perfect. And is that going to be a 100% webinar, or are we still looking at doing that as part in person, but if people can't attend in person, or it's still dependent on what's happening with COVID restrictions?
Yeah, still dependent. We did reserve the conference space in Hagerstown at Robinwood, but I think we're probably looking at another virtual session. So
Yeah.
To be decided.
Okay, perfect. And finally, Ruth Kirshner, and I'm sure others are asking about the CEUs. Meredith, you want to come on and talk about the CEUs?
Sure. So what will happen with the CEUs is that I have sent everyone who signed up for a CEU an additional link to a registration form that you need to fill out before we can process your CEU. If you have not done that yet, please do so. If you need the link again, please let me know. Once I have all of that information, we'll go through and verify that you were here and that you stayed the entire time, and then we will process the, what's that word?
Certificates.
Thank you. It was just not going to come to me. The certificates as quickly as possible. Please understand, we're a small organization, so it will take me a little bit longer to do all of those things, but I promise you that you will have them as quickly as possible. If you have any questions or concerns, if you don't see your certificate in the next, I would say, week and a half, please feel free to drop me a note and I'll give you an update as to where we are. I'm hoping to be able to finish them all as quickly as possible, but you know, life happens. And then someone else asked about certificate of completion. If you're not taking a CEU, you will also get a certificate saying that you attended the conference today. And that should work for you as a certificate of attendance or a verification of attendance. If for some reason you need more than that, please send me an email and I'll be happy to help you out.
Yeah, as nice as these webinars are that we can bring people together from across the state and even across state lines, ordinarily, if we were meeting in person, everyone would get their certificates at the conclusion of the event. You'd give us your evaluation. We'd in turn give you your certificates, but it does take a little bit longer to get everything processed. But no worries, you will get it. And again, if you don't get it within the next couple of weeks, just reach out to Meredith. So
also, Val, you asked how we know. We've been monitoring the chat and we have a list of participants who've been here. Okay. So if you are doing your CEU, you do need to fill out the pre, the post, and the registration form. We do need all 3 of those from you if you are doing a CEU. If you're not, we would still like you to do all of those things for us. It really helps us. Our funders need that information. It helps us to continue doing the work that we're doing and to provide you better services moving forward. So if you can please do that, I would appreciate it. I sent it again. You will also get an updated resource book because I've added resources as we've gone along. And you will also get the survey, the post survey again in an email in case you can't click it now or you don't have time to finish it. I'll send it to you again, and you should get those 2 things in the next day or so.
Well, thank you. And if we were live, we could all clap and say thank you. But just know there are lots of very positive comments coming in. Great conference, says Carolyn, and Michael agrees. Thank you, everyone. So, just everyone have a wonderful day. Be safe in the snow. We'll see you hopefully at the April 14th conference. Look for information about that. Thank you.
Thank you, Diane.
Thank you, Diane.
Thanks, Cindy.